Welcome back to Clinical History in English. Today's case will be on pelvic pain. You're working in the accident and emergency department and a 31-year-old female presents with lower abdominal pain. You take a history from the patient and record the following. Presenting complaint, lower abdominal pain. History of the presenting complaint. Now, you may remember from previous case presentations that we can use Socrates as a useful abbreviation to order our thoughts and our history taking with regard to pain. So S for site. She describes pain in the right lateral lower abdominal area. O for onset. The patient says that it started this evening whilst at rest, while she was watching TV. C, character. She describes it as an intense ache. Excuse me. R, for radiation. There is no radiation. A, associated sweating and dizziness. A is for associated symptoms, and she describes sweating and dizziness. T, for timing. She describes that it has built up, so it has grown over the last 1 to 2 hours. E, exacerbating or relieving factors. She says there is nothing that has improved or worsened her pain. She took paracetamol and ibuprofen, and that didn't do anything to improve the pain. And S for severity. On the scale of 1 to 10, how severe was the pain? And she gives it a 7 out of 10, so considerably bad. Continuing with the history of the presenting complaint, she opened her bowels normally this morning, so she defecated normally this morning. She denies pain on passing urine. I know medically you can write the phrase dysuria, but often you will find doctors say pain on passing urine rather than dysuria. And there is a little debate about whether dysuria is pain on passing urine or just difficulty passing urine. So to avoid any confusion, I've put here pain on passing urine. She has a normal appetite, no nausea or vomiting. Her last menstrual period, because we're looking at a fertile female, her LMP, she's not sure when her last period was, as her periods are irregular and light due to taking the progestogen-only pill or POP. Some people call it the mini pill for short. And in terms of obstetric and gynecological history, we also include her gravida and para status. Gravida is the number of pregnancies and para is the number of births. So she has had neither a pregnancy nor a birth. She is in a long-term heterosexual relationship with no new partners in the last 4 years. She has no history of sexually transmitted infections. In terms of her past medical history, she had an appendectomy at 10 years old. In the United States, they would call it appendectomy, but in the UK, we call it appendicectomy. We add that extra I and C. In terms of family history, there's nothing relevant to note. Drug history-wise, she has no known drug allergies, which we abbreviate to NKDA, and she takes Cerazette, the progestogen-only pill. She describes good adherence, no missed pills. In terms of her social history, she's an accountant, independent in all her activities of daily living or ADLs. She lives with her long-term male partner. She denies new sexual partners in the last 6 to 12 months. In fact, she said previously in the last 4 years, no new partner. She's a non-smoker and drinks 1 to 2 units about once a month. So she very, very low alcohol intake, and she denies recreational drug use. So what are our possible differential diagnoses? Now, with anyone who's female, we want to think about if they're in the age range between, 14 and 48 maybe. We want to be thinking about pregnancy. And with pain, we're thinking about ectopic pregnancy. It could be ovarian torsion. Pelvic inflammatory disease would seem unlikely given her history, no sexually transmitted infections and no new partner. But it's worth keeping our minds open. We know her history, we don't know her partner's history. And she's had an appendicectomy in the past, so she could be having adhesion-related pain. In terms of ectopic pregnancy, we know that the progestogen-only pill is a risk factor, that if a woman does become pregnant, she has a higher risk of having an ectopic. So it's still a possibility. So let's continue on and we'll look at the observations. Her heart rate is 105 beats per minute, respiratory rate 16, blood pressure 95/64. That may be low or it may be normal for her. Saturations or SATs are 98% on room air, and temperature, which we often abbreviate to a T with a degree symbol in English, is 36 degrees Celsius. In the US, I believe they use Fahrenheit a lot more, but in the UK, we only use Celsius. Right, so on examination, inspection, she does appear to be in pain, but no difficulty in breathing. Her pulse is regular and fast, so slightly tachycardic. Her heart sounds are 1 + 2 + 1, no added sounds, no murmurs. So let's continue on to our abdominal examination. I thought this time it might be helpful to include the different regions that we examine in the abdomen. So we've got at the top our right upper quadrant, epigastric region and left upper quadrant. Right in the middle we've got the umbilical region, and either side we've got the right and left loin or flank, depending which one you prefer. Both are acceptable. And then right at the bottom we've got the suprapubic region, and either side we've got the right and left iliac fossae. Fossa for singular, fossae with an E at the end for plural. So an examination of her abdomen, it is soft, there are no masses. There is tenderness in the right iliac fossa. Oh, there's a spelling error there. It should be FOSSA or RIF, as it's often abbreviated, with guarding but no rebound tenderness. Her pervaginal examination or PV examination revealed no adnexal masses, but right adnexal tenderness. So we've done a few tests. We want to do a urine dipstick and pregnancy test and arrange an urgent pelvic ultrasound scan. And fortunately, bloods have already been taken by the nurse who triaged our patient. So let's have a look at our results. On our urine dipstick or urinalysis, however you wish to call it, there was basically no sign of infection whatsoever. No leukocytes, no nitrites, no red blood cells, no protein, no glucose. And her pregnancy test was positive. Okay. Her blood test results, including clotting, were all within the normal range. So in terms of blood results, there's perhaps, now that we know more of her history, some things we'd like to add to the blood, call the laboratory and add a few tests. So we're going to add a beta human chorionic gonadotrophin. Again, sorry, there's a little spelling error there. Gonadotrophin it should be, or beta HCG. And we want to cross-match 2 units of blood because we're thinking this lady might need some surgery if we're right about the diagnosis. So what are we thinking? What's our working diagnosis or impression? Absolutely, we're thinking ectopic pregnancy. That's the first thing that we need to rule out. So what happened next? Management. Unfortunately, the pregnancy is not early enough to use methotrexate, and therefore she's taken to surgery for a right salpingo-oophorectomy. So they're going to remove her right fallopian tube and ovary. She is advised to abstain from sexual intercourse or use barrier contraception until her follow-up outpatient gynecology appointment, where they will discuss her long-term contraception. So the progestogen-only pill may not be a good option for her going forward, having had one ectopic pregnancy already. But that will be discussed when she's feeling a little better. So let's review the things that we've discussed in this clinical case. Some of the words or vocabulary I think are particularly helpful. So we've got pelvic versus pelvis. Pelvis is the noun, pelvic is the adjective. So pelvic pain, or we're talking about the patient's pelvis. Ache, that's a particularly useful word. I would say it's sort of the opposite of a sharp pain. It's more of a dull pain. But we use it a lot, and you'll be familiar with it from words such as headache, stomachache, earache, etc. We had GOPO. What does that mean? So gravida 0 and para 0. Okay, that's how we abbreviate it. Appendicectomy, just because of the difference between UK and US. Adherence is a really useful word in medicine, isn't it? The patient had good adherence to her progestogen-only pill. And we had the word loin. So that's the loin or flank, which is the two regions either side of the umbilicus, or as we commonly call it, belly button in English. Loin is a useful word when we want to describe kidney stones or renal colic, where we will say the patient often describes loin to groin pain. Groin is the area, the fold or the crease we have on our leg, the inguinal region. So groin is another useful word, and we often describe, probably because it rhymes nicely, for renal colic, loin to groin pain. And then we have the word adnexal to describe the areas when we do a PV or pervaginal examination. And let's have a look at some of our abbreviations, see if you can remember some. STIs, it's a really useful abbreviation to know, even non-medical people are familiar with it. Sexually transmitted infections. LMP, last menstrual period. POP, progestogen only pill. PID, pelvic inflammatory disease. RIF or RIF, right iliac fossa. So when we think of appendicitis, we often think of the right iliac fossa. PV, pervagina or pervaginal. RBCs, red blood cells, RBCs. And we have HCG, which is basically the pregnancy test, human chorionic gonadotrophin. And that's all for this time. Hope you enjoyed it. If you did, give us a like. Feel free to write a comment or ask a question, and to follow us at Clinical History on both Facebook and Instagram. That's all for now. Take care. Bye.